Good afternoon. On behalf of Pella Medical Center and Spartanburg Healthcare System, I welcome everyone and thank you for joining us today. I'm Lindsay Lewis, the Manager of Community Outreach. Our speaker today is Dr. Shawn Birchenough, Chief of the Plastic Surgery Division at Spartanburg Regional. He is a board-certified plastic surgeon that specializes in breast surgery and cosmetic surgery. He is also the current president of the South Carolina Society of Plastic Surgeons, leads the Plastic Surgery Club of the Upstate, and is a member of the American Society of Plastic Surgeons. If you have any questions in the upcoming presentation, please type them in the Q&A box, and I will ask them to Dr. Birchenough at the end of this presentation. And now it's time for our presentation, titled Blow the Whistle on Skin Cancer. We're very pleased to have Dr. Birchenough join us today for this presentation. Welcome, Dr. Birchenough. I will now turn the presentation over to you.
Okay, thanks, Lindsay. This is Shawn Birchenough. And as she mentioned, I am a board-certified plastic surgeon. I do specialize in skin cancers of the face, particularly. So that's where the conference today will be concentrating. We'll be talking about skin cancers, particularly of the head and neck. And one correction, I'm a past president of the Plastic Surgery Society of South Carolina. So. But let's go ahead and get started, and remember to type in your questions so that we can answer some relevant things from the audience. Again, thanks for joining us. So this is a brief outline of what we're going to be talking about today. We'll talk about the skin anatomy, the different types of skin cancers, how we identify skin cancers, treatments that we use for skin cancers. We'll talk a little bit about a few cancers that I've treated, and then, of course, we'll talk about prevention and surveillance as the primary way to help avoid getting skin cancer. So, and I would assume that of all the people watching, several of you probably have been diagnosed with skin cancers, as they are a very common type of cancer. So let's jump into the skin anatomy and talk about this amazing organ. So the skin itself is a very large organ. It is the largest organ in the body, actually. And so if you spread it out, it'd be 20 square feet, which is imagine a piece of paper 4 feet by 5 feet. That's how much skin you have. So it's a humongous area. So, and it's almost 20% of our total body weight. So it's a very complex structure. It has a number of functions, obviously. Some of the cells that are in the skin are squamous cells, basal cells, and melanocytes. So we'll be talking about cancers that come from these different types of cells. So, to be clear, squamous cells and basal cells are normal cells in the body. So it's when they become cancerous that we talk about skin cancers of these types. And then melanocytes are the pigment producing cells of our body, and they can become cancerous as melanomas. So our skin has a lot of functions. Particularly important is regulating our temperature. So it's the primary way that we regulate temperature. There are other secondary ways, but by far it's the skin that does it for us. So it helps keep us hydrated, maintains our hydration. Obviously, it helps us against infections. So it's our primary source of protection against infections and staying immune. It's a very important vehicle for transmitting touch. So whenever we interact with our environment, it's mostly through our skin that we're interacting with the environment. So obviously we have sight and hearing, and we do have taste buds. The skin is very important for how we interact with the environment. And not to be dismissed, the way that we look has a lot to do with our skin. So the cosmetic functions of the skin are also very important. So the primary protection that the skin offers is from environmental toxins, and that can be a number of things. So it can be chemicals, it can be gases, it can be liquids, it can be other injurious types of sources of things that are trying to get into our body. So it can be small microbes, it can be bacteria, it can be viruses. So our skin is our primary protection against these environmental toxins and these insults. So it also provides tremendous protection from ultraviolet radiation and the sun. So, and this is the primary point of what we talk about when we talk about skin cancer and skin cancer prevention. So if you if you look at the little diagram on the right, this is a very simplified version of what our skin looks like, and you can see that it's several layers. There's actually 7 layers of different types of cells within the skin itself. The top layers are not alive, but they're very important in terms of their function. The bottom layers are alive, and then there are multiple other structures besides the cells that are in there, including hair bulbs, sweat glands. There's different types of glands actually that also exist there. And below that is our fat and the primary blood flow to the skin. So this is very simplified, but it gives you an idea. There are also nerves that come up through here that are not shown, and a number of other specialized structures. So moving on to skin cancer. So cancers of any type are almost always cells that have grown out of control, and they are normal cells that are crowding out other normal cells. So the cells themselves are have been ramped up in terms of their ability to divide. So, and there's no check on them, so they don't stop dividing, and they don't get the signal to stop growing. So essentially that's what all cancers are, and skin cancers are no different from that. So the 3 most common types of skin cancers that we'll be talking about today are squamous cell carcinoma, basal cell carcinoma, and melanoma. So as I mentioned, basal cells and squamous cells are normal, very important cells that we have in our body. So it's when they grow out of control that they become carcinomatous or cancer cells. So melanomas are cancers of the melanocytes. So, and we'll talk a little bit about that. So a lot of them are slow growing, and they're usually easy to treat if they're detected early. So in addition to prevention, surveillance is another thing we'll discuss in more detail. So it's very important to catch these early, because the smaller they are, the easier they are to treat. So, and many of them are created or are made worse by ultraviolet radiation. And the primary source of ultraviolet radiation in our environment is the sun. So that's why we stress so much about sun protection. And particularly in places like South Carolina, we get a huge amount of sun for a long period of the year, and people are outside a lot because it's warmer. I grew up in northern New York, and so we get sun in the winter, but you wouldn't want to be outside most of the time because it's so cold. So being warm here a lot has people outside in the sun a lot. So other sources of ultraviolet radiation are tanning beds. Of course, we know about those, and we know that with ultraviolet radiation, the changes that we see in our skin is that we turn darker. So back in the 70s and 80s, everyone talked about healthy tans, and so how tans were very healthy. We certainly know now that that is not the case. So tans are not healthy. And I want to try to dispense that myth, because what your body is doing is it's crying out for help. It's trying to say, I'm getting too much sun, and the only response I can do, I can't send you an email. All I can do is turn browner. So the browner I turn, the more damage I have, and it's the only response that our skin can give. Now, obviously, if it's acute sun injury, you turn very red, so everyone knows about bad sunburn. So, but long-term, brown is the color that we turn, and that has to do with the melanocytes. So the melanocytes themselves are reacting to all this ultraviolet injury, And the only reaction they can do is to make more brown pigment and push that up to the top of the skin. So we think of it as healthy. We know now that it's just a response to a lot of injury. And so it's this accumulated injury, ultraviolet radiation, causing our melanocytes to create more brown stuff that is its response to our to injury. So, and the lighter your skin is, the more affected you are going to be by this ultraviolet radiation. So, so that's why people who have blue eyes, blonde hair, light skin tones are going to be more severely affected by ultraviolet radiation because they don't have any natural protection in their skin, or they have very little natural protection in their skin. So, but that doesn't mean that people with darker skin can't get skin cancers. They do, and they do have to be checked and be careful. So we already mentioned this once. These are the three major types of, or the three major categories of skin cancer. The two on the left, the basal cell carcinoma and squamous cell carcinoma, are considered to be non-melanoma. So on the right, we have an example of a melanoma. So we make a distinction between these because of the severity of melanomas and how they can significantly affect your overall health, and the possibility of death is a lot higher with melanoma than the other two. So we split them up in our minds between non-melanomatous and melanomatous skin cancers. So basal cell and squamous cell are two types of non-melanoma skin cancer. So let's dive into these because they're very common. So in the United States, we see at least 1 million cases of basal cell and squamous cell per year. So these are very common cancers. They're very easily treated if they're caught early, and so we see these fairly commonly. And again, I would guess that of all the people watching or listening to this program today, many of you have been treated for basal cell carcinomas or squamous cell carcinomas. So they're usually found in places that get sun: tops of the ears, the nose, the cheeks, the backs of the hands, and the forearms. Those are the most common sites that we see basal cell and squamous cell carcinomas. So now it isn't, these aren't taken completely lightly because we do have at least 3,000 deaths per year from either basal cell carcinoma or squamous cell carcinoma. So these are cancers that can metastasize, which means they can go to other parts in the body and spread to the lymph nodes and spread to other organs in your body. So we do want to take care of these. We do want to treat them when they're small. Moving on to melanoma. So this gets our hackles up as plastic surgeons and dermatologists and general care physicians. And the reason is because even a small melanoma can kill somebody. So it doesn't take much for melanoma to spread to other parts of the body. So you can see that where we talked about 1 million cases of basal cell and squamous cell carcinomas a year, there's only about 70,000, give or take, of cases of melanoma in the United States in a year. But there are 3 times as many deaths. So you're talking about less than 10% of the total number of skin cancers, but yet 3 times the number of deaths. So it shows you that this is a very deadly type of skin cancer. So that's why we get very concerned about melanomas. So, and as we mentioned about lighter skin and darker skin, it is 10 times more common in Caucasians than African Americans. However, that does not mean that African Americans don't need skin checks, because they can get melanomas. They can occur in places that are less common than Caucasians. So the melanomas can develop anywhere on the body. They are more common in the sun-bearing areas, but you can find them on your back, you can find them between your toes, you can find them in your your scalp. There are places that are very hard to find, and these can be very small, but still cause a potential risk to someone's health. So we know that sun has something to do with melanoma, and it has to do with the lifetime exposure. So we know that your chance of getting melanoma goes up if you remember a sunburn as a kid. And how many of us over the age of 50 didn't have a sunburn that we remembered as a kid? Of course, we all did. So that means we're already in a higher risk group if you've had sunburns and sun exposure, but that continues throughout your lifetime. So the more sun you get, the higher your chance of melanoma. So, and as I mentioned, these are much more likely to metastasize, which means spread to lymph nodes and other organs in the body. And that's where the death rate comes from. So these are particularly hideous skin cancers, and we treat them appropriately. So, okay, let's talk about melanoma and some things that we look for in terms of places on your skin. So we talk about the ABCDE'S, and so initially the A we talk about is asymmetry. So if you look in the left column of those moles, everybody calls these moles. These are not all moles, but in the left column, you can see something that has a very distinct border, and it has a very symmetric shape, where in the right column, that's a melanoma, and you can see that there's a central portion, and then it kind of spreads out in this indistinct way, kind of in a non-symmetric way. So that would clue us in, particularly that and the color, we'll get to that. But that would clue us into that skin spot and say that needs to be investigated further and needs to be biopsied. So the border of it, so the second one, the B, you can see the border in the left-hand column of images has a very distinct border. It starts and stops. There is something that's different about the skin, and then there's normal skin. And then where in the right picture, you can see it's very hard to say, where does this actually stop? There's some areas that almost look shaded in, and that indicates something that also needs to be biopsied and looked at very closely, because we worry about that for melanoma. Color. So you see in the third set of images, there's a very uniform color. So if your moles have a uniform color and they have a normal border and they haven't been growing much, then we know to watch these things. However, as soon as the color starts to change, if you have multiple colors in a mole, or the colors are changing over time, then you get concerned. As it gets darker, we worry about that. But you can see in the right hand image, there's multiple colors there. There's some browns, there's some darker blue hues, and then there's some light tan, and all of that gets us very suspicious. So diameter, so we worry, and you can't tell from these images exactly how big these are, but we basically talk about the size of a pencil eraser. That may be getting old school, because I don't know how many kids use pencils anymore, but if you can imagine, you take the pencil eraser of a standard number 2 pencil, and if you can't cover the whole skin area that's changing, then you need to have it looked at. So, and the one on the right, if you can imagine, would be bigger than a pencil eraser. So, and then the E is evolving. So if things change, we all have moles, we all have normal skin changes that occur throughout our lives. So, but if you start seeing ones pop up, particularly if they're coming in one area and they're changing quickly, that's an indication potentially that it's melanoma. All right, so who's at risk? We already talked about this to some degree. So light skinned people, blue eyes, freckled people, people with blonde hair or red hair, those are at risk. And that's because our natural protection, which is melanin, which is the brown pigment, isn't in as high of a concentration in them naturally as in other eye and skin and hair colorations. So people in the sun, people who were farmers or who are farmers, landscapers, construction workers, people who golf a lot, people who are outside a lot, those are also higher risk patients, and certainly here in South Carolina, we all like to be outside, and maybe too much. So people who are on immunosuppression, and immunosuppression is a wide range of medications that are used to treat things like rheumatoid arthritis. They're used to treat some cancers. Sometimes, certainly people who have had transplants are on some type of immunosuppression. So these are things that increase our risk of getting skin cancers in general. And the reason is because if we were to develop a skin cancer, our body has mechanisms of identifying it and taking care of it and killing those cells. So we all make cancers fairly frequently in a lot of different parts of our body, but our immune system is clearing those out. So they attack them, they take those cells, and they get rid of them. If your immune system is suppressed, then you're going to end up with a higher likelihood of certain types of cancers, and skin cancers are one of them. So certainly if you have a family member that's had skin cancer, another risk factor. And then older adults, as we age, our ability to clear the small cancers that we make and take care of them ourselves goes down. And we have more cumulative sun damage, so that UV damage over time builds up year after year. So that's where we see older patients with more skin cancers. We talked about UV light very briefly. This is a part of the spectrum ultraviolet, which means it is not light that we can see. You can't see ultraviolet light, so you can't see infrared light. So you can see on the spectrum, the EM spectrum, our visible light is a very small portion of what we're getting hit with all day, every day, from X-rays to ultraviolet lights to infrared. So within that ultraviolet spectrum, we know that UVA and UVB, two types of ultraviolet, are much more significant in terms of their contribution to skin cancer. And this is light that comes from our sun. So our sun gives off a lot more than just what we can see. It obviously gives off infrared rays because it's warm. So it gives off X-rays, it gives off ultraviolet light as well. A lot of that ultraviolet light is absorbed by the atmosphere. So a lot of ultraviolet is filtered out before it gets to us. So as you know, well, maybe you don't know, but if you fly in an airplane, you're actually higher up and you have less protection against all of the light from the sun. So you're at higher risk of getting more X-rays. More ultraviolet light also can get through. Obviously, you're protected more in an airplane from the ultraviolet light because the airplane shell itself will protect you. But the X-rays actually go through the airplane. So when you're flying, you get more X-rays than you do when you're on the ground because of the amount of atmosphere. So UVA and UVB, you've probably heard of those. Certainly we know about it for sunglasses, but this applies for the skin. They both contribute to skin cancer. And you can see that skin damage from UVA is also something, wrinkles, which none of us like, obviously. And then UVB actually changes our DNA, and that's where some changes can lead to skin cancer. So tanning beds have UV light, which can be as strong or stronger than what we're getting from the sun. So we know that we have a significant increase in melanomas among people who were tanning in their teens and 20s. So again, they didn't get melanoma in their teens and 20s. They got it in their 40s, 50s, 60s, and 70s, but it's because of the cumulative damage, them starting out with a lot of damage in their teen years. Sun protection. So that's probably the best thing that we can talk about today, and that includes trying to avoid being outside between 10 and 4 p.m., 10 a.m. and 4 p.m. So that's when the sun is directly overhead and the rays are the strongest. As the sun sets or as the sun's rising, the light rays are more spread out, so they're not as intense. So wearing sunscreen, we all know about wearing sunscreen. This is a message that's been pounded into us for the last 30 years. So, and I'd say that even that 15 plus should be higher. If you're outside and active, you're talking about 35 to 40 SPF plus. And you have to reapply. Most people think I'd put it on at 8 a.m. Well, by 10 o'clock, that is almost not doing much helping in terms of helping you protect against the sun. So you need to reapply every 2 to 3 hours, even more often if you're in and out of the water. So at the lake or in the pool, you have to apply your sunscreen often because the protection, it just isn't there. So, and you can see in that picture on the top right there, what that is a special photograph that's looking at ultraviolet light on the skin and what it looks like to ultraviolet light if you have sunscreen. So you can see the side that has sunscreen on and the side without sunscreen. There's a significant difference in terms of how much of that ultraviolet light is being absorbed into the skin. So you can't see that based on normal visible light. It's only in that ultraviolet range that we can't see that does it. So hats and sleeves. So when I'm outside working in the garden or playing golf, even if it's 90 degrees, I wear a long sleeve shirt because that at least covers my arms up. I wear gloves, I wear a wide hat, and I wear sunscreen. So you have to cover up. So no tanning beds ever, not when you're young, not when you're middle-aged, not when you're old. They just are going to create more damage to your skin long term. So, and everybody has sun damage. It accumulates year after year. It adds up. So let's move on to cancer screening. So we're talking about skin cancer screening. So this is with a dermatologist. Typically, sometimes your primary care physician will do skin cancer screenings, but you want to have an exam every 3 years up until the age of 40. So certainly more often if you've had a diagnosis of skin cancer in that time. So, or if you're at significant risk. So this is just for general population. So after the age of 40, you should be getting a yearly skin check. So, and again, you might even be coming in more often than once a year if you've had a skin cancer diagnosis, and particularly a melanoma diagnosis. A lot of my melanoma patients are being followed every 3 months by their dermatologist for a year or two after their first melanoma is treated. So you're checking your own skin, get to know your own moles. Take pictures of them yourself so that you can look back at it. We have access to cameras now. Pretty much, there's every single phone we have has a camera, so you can take pictures of your own moles and then refer back to them over time to see if they've changed size, color, the asymmetry, if they're evolving. So, and then see a doctor if you notice things. So anything after the age of 40, if you get a new quote unquote mole after the age of 40, then you have to be very suspicious of that. I tell patients that moles, regular looking brown moles that are not asymmetric, that have a very distinct borders, keep the same color, all those ABCs, those are free up until the age of 40. We all get moles as we age, but you shouldn't be getting a lot of new ones after the age of 40. So other indications are places that won't heal up completely. So I hear this all the time. Every day I'm in the clinic, I hear patients tell me, oh, that spot, it didn't heal. It bled a little bit and then it healed over. And then it started bleeding again a few weeks later. That's an indication that there's cancer going on there. So unless there's an obvious reason that it's bleeding, that it's opened up again, you have to be careful about anything that kind of doesn't completely heal or heals over and then comes back again. We talked about the ABCs of melanoma. Here's some other examples of the ABCs again, the asymmetries, the border being indistinct, the color, the diameter, and then of course the E part of it on here. And so you want to be careful of anything that's scaly, bleeding, itching, tender, or that changes a lot. And I know that that's a lot of different things on our skin because a lot of things in our skin that are not cancerous do those things. But you need to have a dermatologist figure out which ones may or may not be more dangerous and ones that need to then be biopsied. So here's melanoma, and we talk about the survival rate. So And you can see how dire this is. So if you have a late stage melanoma diagnosis, and that's stage 3 and stage 4, you have about a 20% chance of living 5 years. So it is a very, very significant disease. So, but if you catch it in the early stages, then you have a 99% chance of surviving 5 years. So that's why it's so important to catch these early, have the biopsies done, figure out what they are, and have them treated. Exam. So when you come into a dermatologist or your primary care doctor, they're going to talk about skin problems. They're going to talk about skin lesions. Lesion is our general term for anything that's different on your skin. That includes regular moles, keratosis, if you've heard that term, actinic keratosis and seborrheic keratosis. Liver spots is the common term for seborrheic keratosis. Those are all normal lesions, and then there are abnormal lesions that can also come about. So you examine your skin, they're looking for sun damaged areas, they're checking your lymph nodes, and then a biopsy may need to be done. A biopsy is taking a small portion of the lesion. So, and this can be done by shaving it off with a razor blade or taking a circular, basically a circular knife and cutting a small piece of it back, and then you get your results, usually about a week. These are not curative. This doesn't cure you of cancer. It doesn't treat the skin cancer. It merely tells us what it is, so then we know how to treat it. So a lot of people come in and they've had a biopsy and they're like, oh, they took care of that one. And it's like, well, it's not taken care of. It's just been shaved off and sent to the pathologist so we can figure out what it is. And now you need to treat it with surgery typically. So let's talk about some treatments of skin cancers, and we're going to concentrate very much on the second one here. So you can get skin cancers frozen if they're very early on, and that's if you've been to a dermatologist, they'll spray you with the liquid CO2, and that's to freeze very superficial, very early skin cancers. Surgical excision is by far the most common and the standard treatment. Sometimes you may need radiation or chemotherapy, and those are for very advanced cases of skin cancer. So who provides all of this stuff? We talked about who does the screenings and the basic biopsies, primary care doctors, dermatologists, and to some degree, some Mohs dermatologists, plastic surgeons, ENTs, and general surgeons may do some screening, but for the most part, we're treating the cancers with surgery, the second column, more than we're diagnosing them ourselves. So, and then other treatments, you may need medical oncologist or radiation oncologist if you get into more advanced treatments like chemo or radiation. So surgical excision is the primary standard of care for nearly all skin cancers of all types. So the first thing we're going to do is cut all of the skin out and make sure we've gotten all of the skin cancer. So it's most important to make sure we have what's called a negative margin. That means the skin around the cancer, around the edges and deep to it, is all cancer-free. So everything we've taken out, we test that not by knowing that there's cancer at the edge, but by knowing there's normal skin all the way around it and all the way under it. So, and these are, some of the providers are dermatologists do that, general surgeons do that, plastic surgeons do that, myself included, ENT surgeons, and then Mohs dermatologists, which is a specialized type of dermatologist. And then reconstruction of that area may depend on the size and the location of the area that was excised or cut out. So let's talk briefly about Mohs surgery and Mohs dermatologist. So this is a specialized type of dermatologist who's trained in cancer excisions, particularly of the face and head and neck and other areas where preserving skin is important. So the important part is that they do the excision and then they look at it. You can see number 2 there. They actually have their own lab and they look at every slice of the cancer to make sure that it was cleared. And then what they'll do is they'll take another area if they see that some of the cancer is still left behind based on the slides, based on the pathology. But they do their own pathology in their office while you're sitting there. So if you've ever had Mohs, you know it may take 1 or 2 or 3 or more excisions to get all of the cancer cells gone, and they can tell that by looking at by staining the cells and looking at them under a microscope. Most of the time, most dermatologists will sew up their own patients. So they close them up themselves, or they do a small flap. So sometimes they would send them to me to do more complex reconstructions, and that's where plastic surgery comes in. So this is an area, this is just one example of an area it's very difficult to see, but she had a cancer of the lip. This was a squamous cell carcinoma, actually, and it needed to be excised. It was taken out by Mohs, and then I reconstructed it. Pictures aren't in there, but essentially you have to bring the lip together and sew it back up. So, and usually I do these in the operating room. Here's one of a basal cell on the cheek that was closed just by stitching it up. And then there's one on the scalp that was closed in this T-shaped, and you can see the immediate post-operative images of those. So here's a basal cell that was removed under Mohs dermatology. It was excised. You can see it there in the first picture. The second picture shows what it looks like when it's been removed, and you can see that's fat in the base of underneath the skin, and I bring it together by doing flaps, what I call flaps. Those are small little skin areas that are brought together and sewn up. So, and that one you have to be careful of because of the eyelid, particularly. You have to make sure that you don't pull the eyelid down or scar the eyelid. So here's a much larger one. So this is a melanoma, and you can see if you see that top image, you can see there's kind of a big dark line, and then there's a circle, a big circle and a little circle. The little circle is where the melanoma is. So that's the melanoma in the middle of the little circle. Outside of it is what we have to remove. So you can see that the amount of skin that we have to take out for melanoma is much, much larger. So, and the reason is because we want no chance of any single melanoma cell being left because of how dangerous they are. And then what I did was lifted up the skin of the cheek and the neck, and that's what that middle picture is. And then rotated that up and rotated it forward so that I could close the wound. So it's a big wound in a very delicate area because there's a lot of nerves in this area that run our face. So very specialized type of flap for melanoma. This is a specialized type of nose reconstruction. So this is taking, you can see there was a basal cell at the base of her nose on the left. It was removed under Mohs, and you can see it's a through and through defect, meaning the entire nose thickness has been removed. And then reconstruction is with multiple surgeries. This was a multi-stage reconstruction with what I call a pedicled island flap, and that takes the skin from your cheek and rotates it up and puts it there. And then you divide it a few weeks later. So the top right picture shows it attached to the cheek still. So it's almost like it's attached to the nose and the cheek at the same time until it grows into the nose. I have one of these to do after this presentation. So I've got the same surgery coming up. I do a lot of those. So there's lots of other photos out there of on the internet of skin cancers and Mohs defects and flaps and all that stuff now that we didn't have when I started training. So let's summarize and then we'll get to your questions. So prevention is by far the best thing. So avoid the sun, tell your grandkids and your great grandchildren that they need to start early avoiding the sun. So check your own skin, know your moles, know the things that are changing, get an exam once a year, have someone check you over, whether it's your primary care doctor or dermatologist. So, and then remember that surgical excision is the primary treatment. So that's how we treat most skin cancers. Some require more work than that, but that's the way we treat them. And then the last thing when it comes to sunscreen and sun protection, slip, slop, slap, and wrap. So slip on a long sleeve shirt, like I mentioned, put sunscreen on, don't forget to reapply it every couple of hours because it is not going to protect you for more than 2 to 3 hours at its maximum. So wear, slap on a wide brim hat and put on a pair of sunglasses to protect against skin cancers of the eyes. You can get melanoma in the back of the eye, actually. So wearing sunglasses as well. So that's the end of the presentation. Here are some of the references and images that I used from the in the presentation, and I'd be happy to answer questions now. Thank you.
So much, Dr. Birchenough. That was a wonderful presentation. I know I learned a lot, so I hope everybody tuning in did as well. We do have a couple questions I'd like to get to before we wrap up, and they all have to do with sunscreen. So the first question is there really a big difference in SPF 15 over SPF 100? Because I know there's been some controversy with that. So can you explain that in a little bit more detail?
Yeah, and this is a tough topic because patients ask me all the time. So I think if you were to draw a line as to where that you should probably be at least and above, 30 is the number that we agree on now. So SPF 30, so less than that's probably not going to be very effective. More than that, it probably doesn't make a difference between 30 and 50. So the more important thing, which I think pretty much everybody forgets, is to reapply it. So if you have SPF 30, you got to put it on every 2 to 3 hours. If you have SPF 50, you have to put it on every 2 to 3 hours. So it's not going to give you extended life if you put on 100. So put your sunscreen on and reapply. So, and I think 30 is really the best number. That should be the minimum. That's what every kid should be using. Every adult should be using SPF 30 or above. Once you get above it, probably doesn't make a huge difference. And whether you can even measure SPF at a level of 100 is still controversial. So 30 to 50, you'll be fine. Just reapply it. Now, one thing is make sure that your sunscreen now says block. It has to say block on it. Somewhere on the label, it has to say block. And this has changed in the last 20 years. Some of our audience will remember zinc back in the 1980s. So zinc was what lifeguards used on their noses. There was that really white, very protective sunscreen. That kind of went by the wayside. So people didn't like how white and chalky it was, so they stopped using it and other formulations came along. We know that the chemicals that were used in those sunscreens from the 90s until the early 2000s are actually not very effective. They're cancer causing in our own bodies and they damage our environment. So they have pretty much effectively been removed from the market. So these nice sunscreens that we had in the 90s and 2000s are no longer available and shouldn't be used. Actually, in Hawaii, they outlawed them because of the damage to the reefs that they were causing. So now everything has gone back to zinc, interestingly. So your first ingredient or the second ingredient on the back of your sunscreen should be some zinc compound. It will be whiter than our old sunscreens. So it will make your skin whiter. And there's not much they can do. They're trying to include zinc in these sunscreens and make them a little bit more friendly so they're not so sticky, so they're not so chalky. But in the end, we need zinc on our skin. That's the best protection. And the reason is because zinc actually blocks UV light. So it's not allowing the light in. The way the older sunscreens worked was a little differently. What was happening is it was actually allowing the UV light to come into the skin and be absorbed by the skin. And then those particles within the old sunscreens were preferentially sucking up the UV light. But like I said, there's been some cancer-causing agents that have been identified. They're not good for the environment, and they've pretty much been removed from the market by almost all reputable sunscreen companies. So get zinc, get it on, and do it often. And another thing is you can't keep using the same bottle of sunscreen for years. So the chemicals break down. They're not as effective. I would say if you can't remember when you bought the sunscreen, then it's too old, go buy another bottle. So usually a year you'll be okay, but anything over that, I wouldn't try to think that it's going to have the SPF protection that it says on the label if it's more than a year old.
Wonderful. Thank you. You answered a couple of questions in that. That was wonderful. I appreciate it. So with answering those questions, my last question goes to about spray tans. So we know that being in a tanning bed is not good for us, but do you have any suggestions on or recommendations about spray tans, if that's okay for women to get?
So probably not going to cause skin cancers or increase your risk of skin cancers. I just wouldn't want people to do that and not put on sun protection because they're not protective. So spray tans are not your natural body's protection against the sun, like us getting darker. So and so it's not going to provide protection. You still need sunscreen if you have a spray tan. But as far as we know, most of the spray tans are not going to aren't going to increase your risk of skin cancer in and of themselves. So, and it may seem like a little bit of a paradox when I mention that our skin gets browner with injury and brown skin is less likely to get skin cancer. People will be like, well, I should just be out having a tan every single day. I should be tan all day, all year, and I'll never get skin cancer. It doesn't work that way. There's a natural color to our skin, and that's a baseline color, and that's where we live. And if you're white skinned, that's where you were born and that's where you're going to stay. So any change above that is injury to the skin. So people who have natural skin color, have browner skin, are naturally protected. It's not that you can create more protection by going out and creating your browner skin. Does that make sense? So it's a little bit of may seem like a paradox, but you're born at a certain level and you can't change that. Any brown that you're increasing in your skin is injury and increased risk of skin cancer, not further protection.
Yeah, that definitely makes sense. I appreciate you answering those questions, and I just want to thank you again for presenting for us today. That was a wonderful presentation. Lastly, I just wanted to remind everyone about our next upcoming virtual presentation, which will be next Wednesday, August 4th. And that presentation is titled Living Life After a Cancer Diagnosis. If you haven't already registered, you could register at www.srhs.com/events. Thank you, everybody, for attending today. Have a wonderful day.